Good afternoon and welcome to today's webinar, Substance Use Disorder and Confidentiality in the Primary Care Setting. My name is Jennifer Trujillo and I am the Substance Use Disorder and Special Populations Program Manager at Nevada Primary Care Association. Nevada Primary Care Association is a nonprofit organization dedicated to improving access to high-quality, community-based, affordable primary health care in Nevada. We provide training and technical assistance to community health centers and partners to improve access to health care for all, especially for the underserved and uninsured populations. For more information, visit us at nvpca.org. This training is a partnership between Nevada Primary Care Association, the Opioid Response Network, and the Center of Excellence for Protected Health Information. I just wanted to take a moment to thank them for helping us coordinate this session. Before we get started, I would like to go over a few housekeeping items. During the presentation, please make sure to mute your phone or computer so that we don't have feedback or background noise. Also, please be sure not to put your phone on hold or we will hear your hold music. You will have the opportunity to submit your questions to today's presenters by typing your questions into the chat panel. You may send in your questions at any time during the presentation. Questions will be collected and addressed during the Q&A session at the end of the speaker's presentation. Today's sessions will be recorded and slides will be available to participants. I would now like to turn over the presentation to the Center of Excellence for Protected Health Information to introduce today's speakers.
Good afternoon, everybody, and welcome to today's webinar, Substance Use Disorder and Confidentiality in the Primary Care Setting. My name is Michael Graziano, and I'm the Project Director for the Center of Excellence for Protected Health Information. Our presenters today are Jacqueline Seitz, Health Privacy Lead for the Center of Excellence for Protected Health Information, Christine Kuyken, Health Privacy Associate for the Center of Excellence for Protected Health Information, Caroline Waterman, Substance Disorder Lead for Center of Excellence for Protected Health Information, and myself, the Project Director. So, funded by SAMHSA for a period of 5 years that began in September of 2018 and goes until September of 2023, the COE-PHI is a partnership between CAI and the Legal Action Center. And what we're charged with is developing and disseminating resources, tools, and other forms of technical assistance for our target audiences, which include patients and families, communities, educators and school administrators, healthcare providers and administrators, and state agencies, with the goal of improving understanding and application of federal privacy laws and regulations, specifically around HIPAA, FERPA, and 42 CFR Part 2, when providing and receiving treatment for substance use disorder and mental illness. The resources, training, and technical assistance, and any other information provided through the COE-PHI do not constitute legal advice. So at this point, I'd like to turn things over to my colleagues at the Legal Action Center to continue today's presentation.
Thank you, Michael, and thank you everyone for joining today. My name is Jacqueline Seitz. As Michael said, I work for the Center of Excellence for Protected Health Information. So today we will be looking at the federal privacy law for substance use disorder treatment information and how to determine when and whether it applies to primary care settings like CHCs and FQHCs. We will be going through the analysis of whether Part 2 applies and then practicing that analysis with a number of case studies. If you have any questions during this webinar, feel free to chat them into the chat box. Or you can also chat in things like, I can't hear you, or I don't understand those acronyms. Can you please clarify? We're happy to respond to any set of questions. It will make the training better for everyone. So feel free to use that chat function liberally. So once we go through the analysis of determining when Part 2 applies, can we go back to the last slide, please? We'll then be looking at how to share Part 2 records internally and how to share Part 2 records with patient consent. And our objectives today are really to determine, first, how Part 2 applies to primary care records, and then second, when it does apply, how Part 2 permits communication in an integrated care setting. So 42 CFR Part 2, the Federal Substance Use Disorder Confidentiality Law. Let's do a quick introduction. Many of you are probably very familiar with HIPAA, which is the general health privacy law at the federal level. So it helps to compare HIPAA and Part 2. They have slightly different purposes, and that purpose comes out in the different scope and functionality of the two laws. So whereas HIPAA applies broadly to the category of covered entities, which includes nearly all healthcare providers, health insurance plans, and healthcare clearinghouses and their contractors, Part 2 applies much more specifically to substance use disorder patient records from Part 2 programs. And we are going to be really working through the definition of a Part 2 program today. And whereas HIPAA generally protects patient privacy and security, Part 2 very specifically protects the privacy and security of records that identify someone as having sought or applied for substance use disorder treatment services at a Part 2 program. Part 2's purpose is very tailored to encouraging people to enter and remain in substance use disorder treatment by guaranteeing confidentiality, whereas HIPAA has a much broader purpose to protect health data integrity, confidentiality, and accessibility. And in the primary care setting, the main distinction that can be drawn between HIPAA and Part 2 is that HIPAA generally permits disclosure without patient consent for treatment, payment, and healthcare operations, whereas Part 2 generally requires patient consent for treatment, payment, and healthcare operations with much more limited exceptions. So to pull out the most important issues from that last slide comparing Part 2 to HIPAA, Part 2 is a federal privacy law. It is specifically for substance use disorder treatment records from certain substance use disorder treatment programs, and it generally requires consent. And I want to flag here that when we're talking about consent in this webinar, we are not talking about consent to treatment. We are specifically talking about consent to authorized disclosure. The term in HIPAA is an authorization. So Part 2 refers to this form as consent. HIPAA calls it an authorization. Some of you may know it by the term ROI, but we are not talking about consent to treatment. When we use the word consent, we're talking about consent to disclose records. So when does Part 2 apply? As I said, it applies specifically to treatment records that come from Part 2 programs, which are federally assisted substance use disorder programs. And the best news I have for everyone today is that not all providers who offer substance use disorder services will be considered Part 2 programs. In fact, it's a very specific subset of providers who will meet that definition, particularly in an integrated care setting. So many providers in a setting like an FQHC will not be considered Part 2 programs, even if they're prescribing buprenorphine for opioid use disorder, or even if they're prescribing other medications to treat substance use disorder. So seeing no questions so far, let's move on to the meat of this first part of our webinar, which is determining what is a Part 2 program. And remember that the reason why it is important to figure out if you are a Part 2 program is that will mean that your patient records are now covered by Part 2. So for to determine whether you're a Part 2 program, there will be these two key questions we'll be working through. Do you meet the definition of federally assisted? And are you considered a substance use disorder treatment program, the way that that term is defined? So let's start with a poll. Before we go through whether or not your program is a Part 2 program, how many of you think that your program or that you individually meets the definition of a Part 2 program? Yes, the poll has now popped up, so choose an option, yes, no, or not sure. Okay, and I think everyone should have had enough time to puzzle through their answers by now. Can we see the results? Beautiful. 60% are not sure, and then the other 40% of you are split. Yes, you think you or your program is a Part 2 program, or no, you do not. So we will ask that poll again in 5 to 10 minutes after we go through these next few slides and see how the answers have changed. Okay, so here is the legal definition that we're working with, just so that you can orient yourself to the way that the law is thinking through this. The two key terms, as I said, will be federally assisted and the definition of program. We've included these definitions in the appendix in case you are extremely curious to see them. But we are going to be working through them now in a decision tree format, which I find is a little bit friendlier to work with. So in case you're not familiar with the decision tree format, first, we're going to ask the question number 1, are you federally assisted? And then we'll follow the decision tree. So if the answer is no, then you can stop. You're not a Part 2 program. And if the answer is yes, then you go to the next question, question 2. are you a quote program, which in the FQHC setting can mean one of two things. Are you either an identified unit or are you identified personnel, and is your primary function providing substance use disorder services? So if you answered yes to question 1 and then you answered yes to either part A or B of question 2, then yes, you are a part 2 program within the FQHC. And if you answered no to that second question, then you are not a part 2 program and you do not need to worry about this unless you're getting records from other part 2 programs. So this is the decision tree that we'll be working with, and we'll be also practicing applying this decision tree to some of the case studies in a few minutes. But let's look at some of the key terminology first so that you can see how that plugs into the decision tree. The first key term is federal assistance. So to the answer, are you federally assisted? To the question, are you federally assisted? The answer will be very simple because the answer will be yes. Because federal assistance includes being a certified Medicare or Medicaid provider. It includes having a Data 2000 waiver to prescribe or dispense buprenorphine. We'll be referring to those types of physicians in the case studies as Data 2000 waivered physicians. And when we say that, that's what we mean, that you are authorized to prescribe or dispense buprenorphine. Or if your program receives funds from any federal agency, which includes HRSA, it also includes if you receive any state funds, if the state received federal block grants. So in the primary care setting at a CHC or an FQHC, you almost certainly will be considered federally assisted. Oh, great, someone asked a question. And so the first part of the answer very simply will be yes. And the question that we have is, if we have funds under the public health law for FQHCs to serve the homeless, aren't we automatically a 42 CFR Part 2 program? The law requires we provide substance use disorder services. And I think the answer is no, you are not automatically a Part 2 program just by virtue of receiving funds through the state law, but you likely, once we work through this analysis, you likely will find that you are. So let's go through a few more slides and then we come back to Mary's question and see if the next few slides of analysis have helped clear it up. Does that sound okay? I realize this isn't a great format for a back and forth answer, so I'm going to move on, but if it's not okay, chat it in. Okay. So are you federally assisted? The answer is most likely yes. So then let's look to the next part of the decision tree, which is on the next slide. Okay, so remember, we've gotten to are you federally assisted, and the answer is yes. So the next question will be, are you a program? And let's go to the next slide because I like how it's a little bigger on the next slide. So as I said before, for primary care settings and FQHCs, there's two ways that you could be a program. One is if you are an identified substance use disorder unit that holds itself out as providing substance use disorder services. So if you're working in a unit. And the other way that you could be considered a Part 2 program is if you individually are identified as a substance use disorder provider and your primary function is providing substance use disorder services. So let's unpack some of those key terms. So the first one, for the identified unit, you should be asking yourself this question if you're working in something like a dedicated substance use disorder care team, even if it includes a variety of providers. So even if it's not all physicians, if it's a physician and a nurse and a licensed alcohol counselor and a licensed drug counselor and an interdisciplinary team, if everyone is working specifically for substance use disorder services, then you will probably be finding yourself in this part of the analysis. So what does it mean to be holding yourself out as providing substance use disorder services? So the next slide will go through some of the examples of holding yourself out that SAMHSA has provided in official sub-regulatory guidance. So you won't find these examples in the law, but SAMHSA, which is the federal agency charged with writing and interpreting these regulations, has listed some of these as examples. The key here is that if the identified unit or the FQHC is holding out the substance use disorder services in such a way that someone would reasonably conclude that a patient who's entering that program is probably seeking services for substance use disorder, then that's considered holding yourself out. So examples include advertising, statements to the community, listings in substance use disorder treatment registries, which can be particularly important in the buprenorphine context. Many people are identified on the SAMHSA Navigator website as a local buprenorphine prescriber, but it also includes certifications in addiction treatment. And if you are identified as the person to go to for substance use disorder questions, then you could be considered to be holding yourself out. Okay, so let's look at this second option for the FQHC setting. So you're not in an identified unit, you're not part of a substance use disorder team. You could still be considered a program if you're an identified substance use disorder personnel, and your primary function is providing substance use disorder services. So what does it mean to have your primary function be substance use disorder services? This is another area where SAMHSA has offered some guidance, but there are not bright lines here. So these are the two guideposts that we have from SAMHSA's recent guidance. 1, occasional prescribing for substance use disorder to a handful of patients does not make the provider's primary function be substance use disorder. 2, this is the other guidepost we have. If you are, if you are only treating patients with substance use disorders, then that would constitute your primary function. Now, I know that you are all identifying that there's a lot of gray area between occasionally prescribing and only treating patients. So is there an exact number of what constitutes primary? And the answer is no. There's no bright line. There's no exact 50% over or under is primary or not primary. So we have to work within this gray zone. We'll be practicing what that might look like in the case studies. The other key term for understanding this second model of, now we're ready for the next slide. The second model of substance use disorder program is understanding when a provider is considered to be identified. And SAMHSA guidance has again indicated that you might be considered identified if you are listed as the facility's main substance use disorder provider. If you are if your picture is on the wall saying, this is our substance use disorder supervisor. And in practice, it probably also includes similar actions to holding oneself out. So the SAMHSA guidance for programs and for large entities about what it means to hold yourself out, those probably also apply to determining whether or not an individual is identified. I see we have another question here. Would one way to test be to run a report by provider of all services provided using codes, I'm going to skip over the acronyms, to determine whether the person's primary function. So you would like to say, okay, let's just run let's run a test of all the different codes that they billed for and see, is that 50% over, 50% under? I suppose that is one way to get to it, but as I just said, there's no numerical definition of what makes primary, so I'm not sure what running that report would get you. Mary, thank you for your questions, and I'm sorry to do this to you twice in a row, but let's see if once we get through a few more slides that helps address, or once we get through the case studies, if that gives you any other idea about what that would look like. Okay, so returning to the decision tree, which is on the next slide, let's look at how the key terms that we just went through plug into the decision tree. So we talked about federal assistance, which is that first question, are you federally assisted? And again, that includes things like being a certified Medicare and Medicaid provider. It includes getting any HRSA money, any state money that comes from a block grant, any sort of federal funds. And it also includes being authorized by the federal government to provide services like being able to prescribe buprenorphine. So the answer will probably be yes, and then you go to the next question, are you a program? So A, are you an identified substance use disorder unit that holds itself out with activities like advertising as providing substance use disorder services? Or B, are you an identified personnel whose primary function, that gray area, is your primary function providing substance use disorder services? And if your answer to either of those is yes, then you are considered a Part 2 program within the FQHC, and you will need to apply Part 2's confidentiality protections to your patient records. And if the answer is no, then you are not a Part 2 program, and again, you only need to worry about Part 2 when you're working with other Part 2 programs outside of your practice. Okay, so Mary asked 2 questions. Does anyone else want to ask any questions before we move into applying this analysis to the case studies? So this is not the end of our discussion about how to apply, about whether Part 2 applies. It is really like a pausing point before we practice applying the analysis to some facts. Okay, so seeing no questions, let's move on to the next section. I'm going to turn it over to Caroline Waterman.
Hello, everybody. Good afternoon. So when does Part 2 apply to primary care practices case study? Next slide, please. So our first case study is sole provider. Many of you have just one physician in your program, so this case study may feel familiar to you. In this case study, we're looking at an example of having just one provider, Dr. A, who is the only Data 2000 waivered physician in the practice who prescribes buprenorphine within this general practice unit of an FQHC. Some of the key factors in this case study to think about are Dr. A occasionally prescribes Espert to some of their primary care patients, and we'll deal with that acronym in a minute. And they are prescribed buprenorphine to only about 20% of their caseload for the treatment of opioid use disorder. Next slide.
Okay, thanks, Caroline. So as most of you know, Espert stands for Screening, Brief Intervention, Referral for Treatment. So here's Dr. A. She has the Data 2000 waiver. She provides Espert to her patients, and she prescribes buprenorphine to approximately 20% of her patients. First, is Dr. A federally assisted? If you think the answer is yes, you go on to the next question. Is Dr. A program? So either is she part of an identified substance use disorder unit, or is she an identified personnel whose primary function is providing substance use disorder services? And then based on that, you get to either yes or no. So let's do a quick poll and see how people are coming out on this issue.
So based on the previous scenario, is Dr. A Part 2 program? We're going to give you a quick, about 10 seconds, a yes or no. All right. And the answer is yes. 60% of you felt yes, and 40% of you said no. Thank you so much for those results.
Dr. A is not a Part 2 program because their primary function is not providing substance use disorder services. That was the key reason why they don't meet the definition. Dr. A is considered federally assisted. She's working in an FQHC, and she has the Data 2000 waiver. She's working in a general practice unit, not an identified substance use disorder unit, so we're not worried about the first option for the definition of program. We're really looking at whether she is an identified substance use disorder personnel and whether their primary function is providing substance use disorder services. So she is identified, but their primary function is probably not providing substance use disorder services. How did we get to that answer? That's on the next slide, 28. So again, there's no bright line for primary function, but these were the factors that we took into account to make that determination. One, she is providing Espert occasionally as part of the primary care services they offer. And two, they're prescribing buprenorphine to only 20% of their patients, which seems like within the realm of occasional or handful, which again are those key terms that SAMHSA gave us to work with. So there's an interesting wrinkle here for Espert. So what if Dr. A had been providing Espert to all of their patients? Well, just providing Espert will not necessarily make you a Part 2 program unless you're also providing other substance use disorder services that would bring you into that primary care threshold. So even if Dr. A here is providing Espert to 100% of their primary care services, if the only other substance use disorder related thing they're doing is prescribing buprenorphine to 20% of their patients, they still would likely not meet that primary function threshold. It would not be a Part 2 program. So we will be covering Espert throughout the next few slides, and I want to make sure that people are thinking about the way that Espert interacts with more traditional and, let's say, in-depth substance use disorder services, for lack of a better word. Okay, I'm going to turn it back over to Caroline now.
All right, so the second case study we're going to talk about is a specialty care team. In this case study, we walk through this example of an FQHC SUD specialty care team. It's made up of one Data 2000 waivered physician who prescribes buprenorphine, again, like our first case study. But in this case study, they also have a nurse care manager and a licensed alcohol and drug counselor. Some of these key factors in this study are this team only provides services to patients with an SUD disorder, but they refer out for more intensive SUD care. They also advertise as a substance use disorder or SUD care team in the materials that are distributed among the FQHCs, and they are listed in the state locator website for SUD providers. And this is how people can seek treatment for substance use issues and can locate services on the website. Next slide.
Great. So again, we will be running through this analysis in order to answer the question. A, do you think that, or I should say, number one, do you think that this meets the definition of federal assisted? If yes, then you ask, is this a program either by being an identified substance use disorder unit that's holding itself out as providing substance use disorder services, or is the primary function to provide substance use disorder services, and is the personnel identified as such a provider? Okay, let's look to see what people think in a poll.
All right, so based on that previous scenario, back. Oh, well, that's all right. Based on the previous scenario in this SUD care team, is it a Part 2 program, yes or no? All right, so 100% felt yes. Okay, thanks so much for voting. Next slide.
You are all wonderful students. So yes, the substance use disorder care team is a Part 2 program because we're working in the identified unit section here. So it's an identified substance use disorder unit that holds itself out as providing substance use disorder services. It's federally assisted, and the key thing here is, what does it mean to be holding yourself out? And this team met that definition because it's advertised by the FQHC and it's listed on the state locator website for substance use disorder providers. So all of that is information being sent out to the community saying, you provide substance use disorder services here, and if I am the patient seeking services, the disclosure that I've received services from this team would basically disclose that I have been seeking services for a substance use disorder. Is this making sense to everybody? It was 100% correct, so I'm going to assume that this part is very clear. If anyone who answered, if the 60% of you who answered incorrectly in case study 1 want to chat in why you thought the answer was yes, or what was confusing about case study 1, I'd be happy to address those questions in the chat box too. In the meantime, let's look at case number 3.
All right. So in this case study, if the integrated model, most of the primary care providers at this FQHC, including the MD, the NP, the RN, and the community health workers, also provide expert services, and 2 of the MDs prescribes buprenorphine. Some of the key factors in this one, there is not an identified SUD provider, and there is not an identified SUD care team. Lots of advertisement in this case study. They took out a full-page ad in a local newspaper advertising SUD services. And the 2 MDs, our Data 2000 waivered physicians, are actually listed on the SAMHSA locator website for buprenorphine practitioners.
Okay, everyone is pros at this now, so let's just quickly go through it. 1, do you think that this team is considered federally assisted? Sorry, it's not a team, it's an integrated care model. So do you think that that this integrated care model is considered federally assisted? And if yes, do you think that there's a program at work here? Either is there an identified substance use disorder unit, or is it an identified personnel whose primary function is providing substance use disorder services? This is really where Part 2 and integrated care mix, and so this will be the key case study to understand for this webinar. So once you've worked through the decision tree, let's go to a poll.
All right, based on the previous scenario, does Part 2 apply to this integrated care model? We'll give you a couple seconds to answer the poll. And so we've got 83% said yes, and 16% said not enough information. Nobody said no.
So this answer will be case specific, and 80% of you thought that you could jump to the conclusion that they would be Part 2 programs, but the reason why you can't jump to that conclusion again comes back to this gray area of whether the provider's primary function is substance use disorder services. We definitely have federal assistance here, and we're not in the Part 2 program model of an identified unit. There is no identified substance use disorder unit. This is total integration of substance use disorder care. And so this will need to be a case-by-case analysis for each individual substance use disorder provider to see if they are, if their primary function is consisting of substance use disorder services. This gets to Mary's question again, which I'll just reread in case people don't have their chat function up. So would one way to test be to run a report by provider of all services to determine, and then you would identify some codes that to indicate substance use disorder care, and then you would determine through some mathematical analysis whether that's primary function. And based on this, that might be, depending on the way that your organization is set up, that might be an efficient way to do it, but that is certainly not the only way to make this case-by-case determination of whether a provider's primary function is substance use disorder services. And I see that we have more questions. So let's see if we can answer this right now. This one? This one. Oh, so someone asks, along with that question, we do have a licensed alcohol and drug counselor, but he doesn't just serve SUD clients. So great question. The clients who are seen by the LADC would be protected by Part 2. Individuals who are not receiving substance use disorder services, including by a licensed alcohol and drug counselor, are not protected by Part 2 because they're not considered patients of a Part 2 program. So let's say they're only getting mental health counseling from the LADC, then their mental health notes would not be protected by Part 2. They may be protected by state law, and they would almost certainly be protected by HIPAA, but they won't be protected by Part 2. So that's a great and very nuanced question. I see that we've had some good questions about holding oneself out. So someone asks, we state on our website that we provide substance use disorder services. Is that enough to constitute holding oneself out? I think we have to list the services we provide on the internet. So under the guidance that SAMHSA has issued, you do not need to specifically state the substance use disorder services you provide. It is sufficient, I think, to just say that you provide substance use disorder services to meet that SAMHSA guidance of saying that you're advertising as a substance use disorder provider. If you have reason to disagree with the interpretation of the SAMHSA guidance, we should talk about that more offline. But I haven't seen anything to indicate that you need to specifically identify the type of services you provide on the internet in order to be considered yourself holding yourself out. And then this second question, wouldn't it meet criteria based on the hold itself out piece due to taking out an ad to promote the services? That's a great question. So Danica, I think that you're referring to facts from, what would that be? Case number 3. So the FQHC took out a full-page ad in the local newspaper advertising its substance use disorder services. And so Danica is asking, doesn't that qualify as holding oneself out? But the holding yourself out definition is only relevant if you're working in the identified unit definition of the program. So I think if we go back to slide 34, this might be useful to go back to that decision tree. So remember, thank you. So remember that in this, the box for number 2, there's 2 models here. One is the identified unit that holds itself out, and the other model is the identified personnel whose primary function is providing substance use disorder services. So to Danica's question, even though the entire FQHC is holding itself out, since there's no identified unit, we don't even need to worry about the holding itself out. That was sort of a fun, tricky part of the question that I hope you were enjoying. Instead, we are not worried about holding ourselves out. We are just worried about whether any of the individual primary function is providing substance use disorder services. Okay, so with that, we can, and there's one more question. First I'll answer Danica's follow-up question. I guess I was confused because it says or rather than and. That's right. So these are 2 alternatives. Alternative number 1 is the unit, and alternative number 2 is the individual personnel. If anyone else is having questions about that, then I can follow up. Otherwise, Danica and I can follow up more afterwards. Let's see, there's more questions. So if you provide the substance use disorder services and it's not a unit, then you're not required to observe Part 2, right? Wrong. If you're not an identified substance use disorder unit, then you look at that second model, which is the identified personnel and whether their primary function is providing substance use disorder services. So you're either a unit or your identified personnel, and there's slightly different factors that go in. So again, this is nice because it helps me underscore my response to Danica. So if you're in the identified substance use disorder unit, then the key issue is whether you're holding yourself out as providing substance use disorder services. If you're not in the unit, then you may still be a Part 2 program if you are an identified individual personnel and your primary function is providing substance use disorder services. Let's take one more question, and then we should make sure to leave plenty of time to discuss how to communicate Part 2 protected records. So it's for the 30/30 grant, which I don't know what that is, but I can imagine. It's for a grant, not for SAMHSA. If we have substance use disorder services listed as a service, and we have a any sort of staff who are diagnosing patients with substance use disorder and providing therapy, does that qualify as a Part 2 program? And the answer here is it doesn't qualify your entire entity as a Part 2 program. It either qualifies the individual personnel whose primary function is providing substance use disorder services, or if they're all working in one unit, then that one little unit would be considered a Part 2 program within your larger general medical facility. Okay, so I think that we are basically at slide 37 right now, which is the question slide. And I do want to make sure we have enough time for the rest of this. So let's go to the next slide. And if we have time, we'll definitely be sure to circle back to the does Part 2 apply question. So after this brief tour through the analysis, do you think now that you or your program is a Part 2 program? Yeah. Okay, so let's see what the responses say. Oh, good. I think that's slightly different, right, from the beginning. So 20% of you said yes, 40% of you said no. I think that number went up, so that's good. And 40% of you are still not sure, which I will take not as an indictment of my teaching skills, but because it is a very fact-specific inquiry, and you may need to take these slides back to your program and think through how your services are organized and whether Part 2 does apply. So again, happy to field more questions, and any questions we don't get to in the chats today, we can follow up via email and phone after today's webinar. So with that, I will turn it over to my colleague Christine for how to share Part 2 records internally.
Thank you very much, Jackie. So again, my name is Christine Kuiken, and I work with the Center of Excellence for Protected Health Information. So now that you're all pros at determining when Part 2 would apply to the provision of SUD services in a primary care setting, we're going to go into a brief overview about how to share records that are protected by Part 2. So the general rule to remember under 42 CFR Part 2 is that Part 2 records may only be disclosed with written patient consent or as permitted in limited circumstances, for example, for internal communications or in medical emergencies. Next slide. In fact, there are 9 exceptions to the general rule that I just described under Part 2 where disclosures are permitted without patient consent. Today, though, we are going to focus on one of those exceptions for internal communications. This is going to be especially relevant for FQHCs or primary care settings where there's a Part 2 program within the general medical facility. Part 2 permits disclosures of patient identifying information without consent for internal communications. And there are 2 types of internal communications. Communications within the Part 2 program on a need-to-know basis, and secondly, between the Part 2 program and an entity with direct administrative control over the Part 2 program. An example here would be an FQHC, which has direct administrative control over a provider who is considered a Part 2 program. As we figured out earlier, that could be just one provider whose primary function is providing SUD services, and they work in a general medical facility in the FQHC. Next slide. Okay, so first we will discuss what it means to share internally within the Part 2 program. Team members that are in an identified substance use disorder unit that is a Part 2 program can share patient information and access each other's patient notes if they need to know the information to conduct their own duties arising out of SUD care. So we're going to describe what that means a little bit now with a case study. Just first, actually, we have a question. I'm actually going to answer this as we go on, so hopefully I will get to your question and let me know if you don't have your answer over the next few slides. Okay, so time for the case study.
Okay, so the first case study is within the Part 2 program. So this case study has a SUD care team within an FQHC, and it's determined to be that it is already a Part 2 program. This team consists of Dr. M, the nurse P, and a licensed alcohol and drug counselor. So Dr. M is prescribing buprenorphine to Joe, the patient, and Joe also meets weekly with the licensed alcohol drug counselor. So next slide, we'll do a poll. So based on this previous scenario, does Dr. M need to obtain written patient consent from Joe to discuss his progress with the licensed alcohol and drug counselor? We're going to give you a couple minutes to do this poll question. Seconds, sorry. Okay, probably long enough. And right now we've got 0 for yes, 80% said no, and 20% said not sure. So thanks for those results, and we'll move on to the next one. Yeah.
Okay, great. So a lot of you got the answer right. The answer is no. Dr. M does not need to obtain Joe's written consent to discuss his progress with the licensed alcohol and drug counselor. It is necessary to Joe's SUD care for Dr. M and the licensed alcohol and drug counselor to discuss his progress. Therefore, that qualifies under internal communications exception, and written patient consent is not needed. Okay, next slide. Okay, and now, so we're going to discuss the second type of internal communications, which is communications between Part 2 programs and the entity with direct administrative control. Part 2 programs can share information to providers and personnel in the FQHC or other entity with direct administrative control, but only if necessary for the recipient personnel's duties that arise out of SUD care. So this may include sharing with the billing department in order to receive reimbursement for the SUD services, or for patient care for another provider that is related to SUD treatment. I think this should answer Eddie's question. Let me know if you need more clarification. Otherwise, we're going to go on to another case study to kind of describe how this works.
So in this case study, we're depicting a scenario between a Part 2 program and an FQHC. So Dr. J, Mary's primary care provider, prescribed buprenorphine for her opioid use disorder. Dr. J works inside the FQHC's general practice unit, but he is not a Part 2 program because his primary function is not SUD services. Mary was originally diagnosed by the SUD specialty care team, which is a Part 2 program. She continues to receive services. Next slide. So based on this previous scenario, can Dr. J and the specialty care team discuss Mary's treatment without her written consent? We're going to do a quick poll. All right, so 50% said yes, 33% said no, and 16% said not sure. Great, thanks for that voting. We'll move on.
Okay, so about half of you were on the right track. Yes, Dr. J needs to access Mary's Part 2 records in order to provide Mary's substance use disorder treatment. And so Dr. J's need for the information arises out of their duties related to SUD treatment. Okay, we're going to do one more case study on this.
All right, so this case study depicting between a Part 2 program and an FQHC. Okay, so in this case study, once again, we have a primary care doctor, Dr. Z, that works within an FQHC and treats Mary, the patient, for pain. Dr. Z wants to know if Mary is receiving SUD services from the Part 2 program within the FQHC. Next slide. So we're going to take a poll. Based on that previous scenario, can Dr. Z access Mary's SUD treatment records without obtaining her consent? Yes, no, not enough information to determine. Take a couple seconds. I'll say 20% said yes, no, no's, and not enough information to determine is 80%. All right, next slide. Thank you for voting.
Okay, great. So I agree with the 80% of you that there is not quite enough information, because here it really depends on why Dr. Z needs to access Mary's substance use disorder records. Is it related to his duties arising out of SUD treatment, or is it related to the Part 2 program's duties arising out of SUD treatment? I'm wondering if those of you who said there wasn't enough information would be willing to chat in and give some examples of how Dr. Z's access may or may not be related to SUD services, or let me know why you chose that answer. Great. So one question is he using opioids for pain management? That would be a good reason why it would be possibly arising out of SUD treatment or not. Right, so another person wrote in, does the Part 2 team have concerns about him prescribing the pain meds? So is there a concern that if he has an SUD, that prescribing pain meds would be inappropriate to prescribe or possibly interact with treatment? Let's move on to our next section where we're going to talk about how to share with patient consent, how to share Part 2 protected with. So again, the general rule is that Part 2 protected records may only be disclosed with written patient consent or as permitted in limited circumstances. Under Part 2, a patient consent form, also known as an authorization or ROI, as Jackie described earlier, must be written, and it must contain a number of specific elements, including a description of the intended recipient of the information. I also want to note here that a consent to disclose information is distinct from consent to receive information. Jackie explained that earlier, and it's very important that we just emphasize that this is a consent to disclose information and is distinct.
And not receive treatment.
And not just to receive treatment. These are the elements here that must be included on a consent to disclose information Part 2. So there are 8 elements here: patient name, information about the party authorized to disclose records, the amount and kind of SUD information to be disclosed, information about who is authorized to receive information, the purpose of the disclosure, the patient's right to revoke consent, an expiration date, event, or condition, and the patient's signature and the date signed. But today we're going to go over number 4, the information about who is authorized to receive information. Under Part 2, a patient may authorize disclosure of their Part 2 protected information to an entire entity that has a treating provider relationship with the individual, which I'll describe what that means in the coming slides. And they also may authorize disclosures to all of their current and future treating providers that are part of a network, such as a health information exchange or accountable care organization. A treating provider relationship is defined in the regulation, and we also have the full definition in our appendix to this webinar. But essentially, health service providers have a treating provider relationship with a patient once they agree to treat the patient. And this can be formed whether or not there's been an in-person encounter. Health providers at FQHCs or other primary care settings will almost certainly have a treating provider relationship with a patient that they have agreed to treat. Okay, and we're going to do a couple of case studies to illustrate how to authorize disclosure to an entity with a treating provider relationship. Okay, so next slide. Okay, so Mary is a patient at Sunshine Center, an independent SUD treatment facility and a Part 2 program. Mary wants her primary care provider and her mental health counselor, both located at Moon FQHC, to communicate with Sunshine Center about her treatment. So how can Mary authorize these 3 providers to share her records? So this is how you would do it. So Mary may sign a written consent authorizing the disclosure as follows. I authorize disclosure of all of my substance use disorder treatment information to Moon FQHC for the purposes of treatment, coordinating care, and healthcare operations. Moon FQHC has a treating provider relationship with Mary because she receives healthcare services there, even though they are not substance use disorder related. And also, I just want to note that, oops, can you go back? Oh. Okay. Mary may also sign a consent form limiting disclosures just to her primary care provider and her mental health counselor, or just to the primary care units and mental health units if she wishes. Just one additional note here, a consent form authorizing disclosure of Part 2 protected patient records must always be accompanied by a notice prohibiting redisclosure. And the reason for that, next slide, is that even when a primary care practice is not a Part 2 program, they may occasionally become a lawful holder if they receive Part 2 protected information about their patients. And lawful holders are also bound by Part 2 and must take care not to redisclose any Part 2 protected information. Okay, so that was just a brief description about consent and sharing Part 2 protected information. So I just want to see if there are any additional questions.
Can I answer Danika's question?
Oh, I'm sorry.
So Danica asks, if we are a Part 2 program, is it necessary for us to have a separate consent form? And feel free to type in more if I'm not getting this question right. So that could mean a couple different things. You probably all have HIPAA compliant consent forms and consent forms that also comply with your state law requirements, if any. If you're a Part 2 program, it's not that you need a separate consent form. You just need to make sure that your consent forms contain all the elements that Christine briefly touched on in order to comply with Part 2. So it's not that you need a separate consent form. You just need to make sure that your consent form meets all of the HIPAA requirements, which I'm sure they already meet, and those additional Part 2 requirements, which get very specific with respect to identifying the party who is authorized to receive information. HIPAA is quite broad in that area, and Part 2 is very specific about how you identify the intended recipient of the information. So Danica, let us know in the chat box if that answered your question, or if you were thinking about a different setup. I don't know your current setup, so I don't know exactly what you meant, but I was sort of guessing that that might be your question. And also, everyone else should feel free to type in their questions. Oh, great. So follow up. Danica says that makes sense. Is there language somewhere that we could borrow? In fact, there is. The Center of Excellence for Protected Health Information has a bunch of resources on our website, including sample consent forms that are organized by the type of recipient, because as Christine said, the way you fill out that to whom section of the consent form, the way you identify the recipient will depend on whether or not they have a treating provider relationship. And so we have a number of different consent forms. So if you're in the healthcare context, you can use our treating provider relationship consent form. And if not, you can use the other sort of general consent form. And those consent forms comply both with HIPAA and with Part 2. Someone else asks, we would also need to include the prohibition of redisclosure language on the consent. That is, so great question. That's technically not required by the regulations. The regulations just say you have to only disclose information pursuant to the consent. And when you disclose that information, you have to include the notice of prohibition of redisclosure. From a practical perspective, it frequently makes sense to just include that notice on the consent form, because a lot of programs, the way that they make disclosures of Part 2 protected information includes the consent form in the disclosure. And then if you have that notice of prohibition of redisclosure on the consent form, you just are sort of making sure you're making it easier for yourself to comply with the law, which is always beneficial. So not technically required, but great idea to just include the prohibition of redisclosure language on the consent form. Okay, so in terms of today's training, key point number 1, Part 2 does not apply to many substance use disorder treatment providers in the FQHC because they're not working in an identified substance use disorder unit, or because they're individual personnel, but their primary function won't be providing that substance use disorder care. So Part 2 may not apply to the majority of substance use disorder treatment providers. Key point number 2, Part 2 will only apply in FQHCs if the providers are working in an identified unit that holds itself out as providing substance use disorder services, or alternatively, if there's an identified provider whose primary function consists of substance use disorder services. And again, there's no point in beating around the bush. that primary function is a gray area and is a case-specific determination in many cases. The guidance we have from SAMHSA is that occasional substance use disorder services would not be primary function, and all of your services being substance use disorder services would be primary function, and then that middle area is just a little squishy. Okay, key point number 3. Part 2 programs may share information internally and within the FQHC on a need-to-know basis, as long as those disclosures are tied to substance use disorder care. And it was very much appreciated that people use the chat function to help brainstorm some of the ways that disclosures could be related to substance use disorder care within that integrated setting. And then key point number 4, even when not a Part 2 program, providers who obtain protected information must still comply with Part 2. So even if this presentation left you with the very confident determination that you are not a Part 2 program, you will likely still run up against Part 2 when you are working with Part 2 programs and specialized substance use disorder providers, either within your FQHC or within the community. And so you will still need to know how to tango with a Part 2 consent form. Here we have one more question. Okay. One question that has come up for us is when we have pregnant patients in our MAT program who have not disclosed this to their OB. This is cause for concern, as you can imagine. What can or do we do in this scenario? So I can't tell you what you should do, but I can tell you what federal law permits you to do. So if you think that this is a medical emergency that you need to notify the other provider about, Part 2 permits the disclosure of protected information to other medical personnel in order to treat a medical emergency, and that medical emergency can be a medical emergency of the patient or a medical emergency of any other person. So it could be of a child. Yeah. So that's the most extreme example. In general, when you're coordinating care between a substance use disorder treatment program and, let's say, prenatal services, those disclosures would be, in many cases, permissible with the internal communications exception, but you can also seek patient consent to make that disclosure. That was another Danica question. Thank you for all your questions, Danica. So if you want to talk more about this later, let's schedule a call afterwards and we can go through some of the details. Here we have another question. Christine, have you seen any questions you'd like to answer?
Okay, if we are an FQHC that provides expert and then refers out to another facility for treatment, are we considered a lawful holder if we try and obtain information from the other facility? That is also a good question. So the answer is, if you do receive those Part 2 protected records from another facility, from a Part 2 facility that is treating your patient, you would become a lawful holder if you obtain those Part 2 protected records from the facility, yes. And then you would have to protect them according to Part 2, those records specifically. Okay, and then Mary asked if we'd be able to look at this page as our website. So you should follow up with us, Mary, about if you have more questions about holding oneself out and whether your program would be considered holding oneself out. We can definitely talk to you about that later. I believe our contact information is on the next slide, and also information about additional resources if you are interested in following up. And we do have a few more minutes if other people have questions.
Hello, everyone. We realize that you'll likely have a lot of questions following today's webinar, and maybe even some questions that don't relate to today's presentation. And here's how we can help. So please visit our website at coephi.org, where you'll find our resource library broken down for each of our target audiences, and a portal through which you can directly request personalized technical assistance. Also, we'll be sharing the slide set with all of you who attended today. And within the slide set, you'll find an appendix containing some helpful definitions and resources, as well as an additional case study to assist you in determining if you or your program are considered a Part 2 program. Okay, and please remember to fill out our evaluation form, which will launch automatically through the web browser when the webinar ends. The feedback that you provide to us is very valuable and will help us to improve on future webinars and other forms of TA. Also, you can contact me directly at michael.graziano@coephi.org. We're going to allow just a couple of more minutes for questions just to ensure that folks don't have any more questions before we close. We know we have some extra time right now.
Okay, so I do see one other question. Providing expert services only does not make you a Part 2 program. Is that correct? So that is correct. If you are a general medical facility, an FQHC, a primary care provider, and the only practice that you engage in related to substance use disorder is expert services, that does not make you a Part 2 program.
So make a pitch for the resources that we have in our appendix in case you just can't get enough. We have we have a different case study. We have the full definition of treating provider relationship. And then we also have information about the buprenorphine locator resource, which is on the SAMHSA website. So if you have any questions about this webinar or our appendix, here's the contact information.
Hey, it looks like there are no further questions. We thank you all for joining us today, especially on a Friday afternoon. We'll give you an extra few minutes back. Please do not hesitate to reach out to us at any time, either through our website or you can reach out to us directly. And we'll be sharing the slide set with you soon. Thank you all for joining today. Have a great afternoon.
Thank you, guys.
Thank you.
Have a great weekend.